We're going to be talking about the management of the small renal mass, and this is really a clinical conundrum. In fact, optimal management of the small renal mass, particularly in the elderly and the infirmed, remains somewhat controversial. And I'm just going to review a little bit of with you before they get up here why that is. And in part it's because there are so many options. You can do open surgery, radical or partial. You can do laparoscopic surgery, radical or partial, or even robotic. You can do ablation, cryo or RFA, open, lap, or percutaneous. You can even watch some of these tumors. And we all have the same goal, to optimize disease-free survival and minimize morbidity. But the problem is we can't base our care on the biological activity or potential because there's no biomarker. And so the two factors that we use mostly in clinical practice are basically a surgeon's versatility, how comfortable he or she feels doing these things, and an informal calculation of the trade-offs. And what are the trade-offs? Well, if you do a radical nephrectomy, clearly there's an implication for GFR and chronic kidney disease. If you do a laparoscopic partial nephrectomy, there are clearly higher complication rates. That's been shown. Thermal ablation, well, there's really no good long-term data. And the ability to salvage a failed ablation with surgery is difficult. And for active surveillance, the predictors of progression are not well known, and there's a lot of patient anxiety. And so what we typically do is you'll hear things like in our meetings, well, I did this because the patient was anxious, or because the patient's performance status was poor, or because the tumor was central, it was big, it was deep. But in truth, we can't exclude our physician biases. We are all products of our training. And some people feel more comfortable with one thing than the other. But what you won't hear is I did this because I know what the biological potential of this tumor is, because we simply do not. And so we've developed a system to try to objectify some of these decisions. We call it nephrometry. That's the geometry of the kidney. And if you look at these four different cases here, I think if I asked any one of the panel members, we may get different answers as to what the best treatment for each of these tumors are. In point of fact, a partial nephrectomy was done on all four of them, but partial nephrectomy is very different from this tumor, which was done robotic, and this tumor, which was done robotic, than from this or this, which was done open. And so we're trying to objectify why we make these decisions and how, and this is one step perhaps in that direction. We'll put up a website to explain it if people are interested. A very brief word about excision. It's overutilized by radical nephrectomy. There are too many radical nephrectomies in this country, and you'll probably hear Dr. Russo tell you this. A recent study from UCSF, 93,000 patients in the National Cancer Database, stage 1 tumors, only 27% of those patients had partial nephrectomy. That's woefully low. And only about 5% had ablation. But it's very effective. We've got the best long-term data for partial nephrectomy. Open partial nephrectomy, 10-year data, 1,200 patients at the Cleveland Clinic. 95% of those patients were cured. They did not have distant recurrence. So good long-term data for excision. What about ablation? Well, unfortunately, the ablation literature is still quite early. This was an analysis, a meta-analysis we published in Cancer, reviewing all of the ablation literature. Average follow-up time about 18 months. In point of fact, about a third of the patients that have ablation, you don't even know what the pathology was that you ablated, and about a 10% recurrence rate for local recurrence. You'll probably hear some of this data from Dr. Kadedu. And what about observation? Well, in the largest series to date in the literature, about 172 patients. It's all retrospective. This is from our institution. A minimum of 12-month follow-up, median follow-up of 24 months of active surveillance. Progression was only 1.3%. And if you look at the waterfall diagram here, the volumetric changes of many of these lesions under active surveillance is actually fairly low. In fact, only very few of these tumors actually grow radiographically when followed for up to 24 months on average. And so the AUA looked at this issue, excise, ablate, or observe, and it came up with a guidelines panel that Dr. Russo and I and many of the members of the audience were part of. And I'm just going to use this to set up the case and the speakers. This is 114 articles reviewed in the literature up to September of 2007. And by the way, the guidelines are available online. For active surveillance, cryo, or RFA, the number of studies is small, the number of patients is small, and the follow-up is short. For excision, the number of studies is large, the number of patients is large, and the follow-up is typically twice as long. The overriding principles of the guidelines are that oncological control is the top priority. Nephron preservation should be attained whenever possible. In fact, a laparoscopic nephrectomy is not a good trade-off in most cases that are amenable to partial. And minimally invasive surgery should be encouraged whenever appropriate. And here are the data very briefly. Urological complications. Laparoscopic partial nephrectomy, highest urological complication rate. Open partial nephrectomy versus cryo-RFA, interestingly enough, they had the same major urological complication rate. And for excision, the lowest, by radical nephrectomy, the lowest complication rate. What about local recurrence-free survival? Excision is associated with the best local recurrence-free survival, and ablation significantly less, according to the AUA guidelines. And so we've developed a comprehensive nomogram to look at competing risks of death in patients with kidney cancer. And this may help guide the discussion whether you should excise the tumor, ablate the tumor, or watch the tumor. And I know that nomograms tend to be complicated. We've just recently had this accepted to JCO. And so I invite you to look at this nomogram. And it sort of predicts if a patient will die of their kidney cancer or if they'll die of some other cause instead. And it may help guide the decision as to whether you can watch these patients or you should actively treat them. So with that said, let me go to the case. And this is a case that none of the panel members have seen. This is a 76-year-old male with a Charleston comorbidity index of 2. He has a past medical history of AFib, and he's on Coumadin. He has a baseline creatinine of 0.95, a GFR greater than 60, and a 2.5 centimeter right renal mass with an nephrology score of 6A, which would predict that that's of intermediate difficulty in excising by partial nephrectomy. Here's the lesion. The key elements here of this case are 76 years old, a comorbidity index of 2 on Coumadin. And we'll start with the audience response system, if you could flip us to that. Would you, in that particular case, excise the tumor, ablate the tumor, or watch the tumor? Granted, some of you don't do this for a living, but again, 76-year-old male on Coumadin with AFib and a 2.5 centimeter upper pole lesion. And as they answer the questions, I think that we'll invite the first speaker up.